We have assembled a panel of experts today representing behavioral health, nursing, as well as lived experience, and it all combines to bring nearly 50 years of professional expertise to today's discussion. I'll start with Mikaela Taylor. She is BrightView's State Behavioral Health Director for Ohio. Her clinical experience has helped BrightView ensure it's providing state-of-the-art treatment to all of our patients. Mandy Seymour is our Chief Nursing Officer, and as we've grown quickly, Mandy's been a critical addition to our team, helping to ensure that our level of care continues regardless of our size. They are joined by Amy Aydelotte. Amy's role at BrightView ensures patients in our communities can find treatment. She has more than 17 years of sobriety and brings a well-informed perspective to her work with our team members and referral partners across the country. And with that, I will hand it off to Mandy.
Thank you so much, Kevin. Good day, everybody. Thank you so much for joining us. Today, we are delving into a critical discussion on a topic that demands our attention: the intersection of medical and clinical factors, external impacts, and effective treatment strategies unique to women dealing with substance use disorders. Let's look at the agenda. In the first part, we'll explore the medical and clinical factors that are distinct to women. Understanding these nuances is crucial for tailoring effective interventions. We'll touch upon aspects like reproductive health, hormonal influences, and other factors that play a significant role. Moving on to the second part, we'll examine the external impacts that come into play. Social, economic, and environmental factors can significantly influence the course of substance use disorders. Recognizing and addressing these external impacts is key to comprehensive and effective care. And then in the third part, we'll shift our focus to the heart of the matter, providing effective treatment. We'll explore evidence-based approaches and strategies specifically tailored to meet the needs of women navigating substance use disorders. This section is going to aim to provide practical insights for clinicians and healthcare professionals alike. And then finally, Q&A. As we wrap up, we want to hear from you. Your questions and insights are invaluable to us. So moving on, next slide. Let's start by looking at the big picture. So overall health. So about 15% of women are telling us that their health is poor, which is a 1% bump from last year. It's a reminder that we need to pay attention to the overall well-being of our community. Alcohol consumption, now not totally surprising, it's reported about 20% of women have had more than 4 drinks in a day at least once in the past year. No change there in recent years, but something to keep in mind as we discuss health habits moving on. And now health insurance and the issue of healthcare access. Around 8.6% of women under 65 do not have health insurance. It's a reminder that we need to work towards ensuring everyone has access to the care that they need. Primary health concerns, so shifting gear a little, we're looking at the big players here. When it comes to heart disease, we have key focus on prevention and awareness. Cancer, it's about screening and support. Osteoporosis, bone health measures, gynecologic health, regular checkups and screening. Mental health, with a major focus in recent years on breaking the stigma and improving access. Diabetes, prevention and management. Obesity, lifestyle changes for a healthier life. And then Alzheimer's, raising awareness and offering support. Next slide, Kevin. All right, let's dive into the crucial aspect of women's health. The societal stigma surrounding substance use disorders is not a level playing field. When it comes to women with substance use disorders, the stigma they face is often more profound or pronounced compared to men. So why is this important? Well, women navigating alcohol and illicit drug use find themselves in an emotional battlefield. First off, they often experience heightened emotions of shame and guilt. These emotions can be overwhelming and act as significant hurdles in their journey towards recovery. On top of that, their self-esteem and self-efficacy take a hit. Facing disapproval and judgment, it can be a heavy burden to carry. Sadly, women with substance use disorder are often devalued and face disapproval, not just from society in general, but shockingly, from other women and those in healthcare. So why does this matter for all of us? These emotions become significant barriers. Shame and guilt become a deterrent for women to reach out for help. It's an invisible wall preventing them from recognizing that they need and deserve assistance and support. This in turn amplifies the treatment needs. When societal stigma is the roadblock, we need to work even harder to break down those barriers and create an environment where everyone feels deserving of help. Next slide.
Hi, everyone. Nice to be with you today. We're going to talk a little bit now about some of the gender-specific barriers when it comes to females getting treatment for behavioral health and particularly substance use disorder. So in addition to the social barriers that Mandy just talked about, women also encounter other obstacles when it comes to receiving care for the disease of addiction or, again, other behavioral health concerns. And, you know, as we were preparing for this presentation, I can't think of any female, and I don't know who's all on this call, but I'm guessing there's a lot of females joining us today that simply fulfill one role. It's not been the case throughout history. It's certainly not the case now. You know, we wear multiple hats as women, albeit partner, parent, employee, extended family roles that we may have. The list goes on and on. And I think that as females, we haven't been conditioned to really put ourselves first. And in terms of, I'm talking specifically about mentally, physically, and spiritually, just our overall well-being. And when you couple this with some of the social barriers that Mandy talked about with the shame and the guilt and some of those things that prevent women from reaching out for help, you couple that with some of these other specific gender barriers, such as financial and basic need challenges. You put in a history of trauma, which is, we all know, is very, very common when it comes to treating these issues. And the female sufferer is very, very complex. Let's go to the next slide, please. And when we talk about how substance use disorder and behavioral health concerns impact females, I mean, there's definitely some significant things that stand out, albeit biologically, psychologically, or environmentally, that move that woman into, unfortunately, sometimes the disease of addiction. The main point that I want to share on this particular slide, and then I want to share with you a personal account, but the main point that I want to stress on this slide is for every 2 men who enter treatment, only 1 woman seeks care. And again, that goes back to the social barriers, the gender-specific barriers that prevent women from reaching out for help or being open to receiving help. And for women in particular, the disease tends to occur more rapidly, and that's what we call telescoping. And telescoping is really where, and you all may know this, but from the initial use of a substance, albeit alcohol or any illicit substance, the dependence upon that substance happens rather quickly. And I wanted to share with you all my personal experience with telescoping, because I really didn't adhere to this. I didn't really think that was true. But of course, for someone who is in active addiction, it's oftentimes hard for us to even believe that we are struggling with something. But from my very first use at the young age of 16, I immediately developed a dependence on alcohol which really started, I would say by the time I was 20 years old, I was already completely dependent almost daily on the use of alcohol. And of course, there's other substances that were involved, but I actually am an alcoholic. And so that's where I tend to find my recovery. But I was shocked at how quickly I became dependent upon the substance. And this went on, you know, I was completely daily dependent by the time I was 20. And then my journey into recovery didn't happen until I was 36 years old. And when you think about just my case, and we're all different, but when you think about the damage that is done, and I will tell you that a lot of the things that Mandy talked about, that I shared with you about these social barriers, they were very, very true for me. I mean, there came a point where you can't even look yourself in the mirror because of the shame. And so think about that. When you're in your own private space and you can't even face yourself in the mirror, the idea of reaching out for help is almost impossible. Next slide.
Thank you, Amy. And I think that what you're talking about really leads into this next section, which really digs into how every single person is unique, but there are specific barriers that women face in recovery. And one of them is actually included in treating co-occurring disorders. So there is evidence that there is gender differences in co-occurring psychiatric disorders for those who are seeking treatment for substance use. Women are more likely to experience a traumatic event and out of that develop post-traumatic stress disorder before the onset of developing a substance use disorder. And oftentimes people who have a dual diagnosis of PTSD and SUD are and were victims of childhood abuse and are vulnerable to repeated traumas in adulthood, perpetuating that cycle because of the environment and the societal expectations based off of how they recover or are trying to recover from those traumas. Additionally, higher rates of anxiety and depressive disorders are often observed in women as well. And in a specific study that this is referencing, it's proposed that comorbid anxiety predicts relapse in female alcoholics. This study recruited 521 individuals who remain abstinent for 10 to 30 days, and they assessed their anxiety, depression, and personality. And the overall relapse rate was 85%. The factors that this study highlighted were that trait anxiety, such as describing anxiety that's part of someone's personality, a way of seeing the world, and low harm avoidance, not likely to worry in anticipation, fear uncertainty, or be shy towards strangers. And I think that what this study represents is really recognizing that a lot of times there are unique struggles that women are wrestling with that are preventing them from even getting into treatment. But once they are in treatment, some of their specific unique issues aren't being addressed early on to help them be able to stabilize and be able to be successful in the long run, simply because of the lack of awareness or information about unique needs that they have that need to be addressed. Next slide, please. Pivoting off of that, I also think it's really important to talk about what does that look like for not only how people are presenting with their behavioral health concerns, but also what that looks like in their environment. So sociodemographics such as their age, their level of education, employment status, marital status, living arrangements, all of those things play a unique and significant role in treatment retention. You know, it's one thing to help someone get into treatment, it's the next thing to help them stay in treatment. And when you have all these environmental barriers and all these hats that you're playing in different roles, it's easy for that to be the priority versus you being able to put yourself as the priority in the midst of all of the hats that you're wearing and the roles that you're playing for people. Additionally, justice system involvement or child protective services involvement is also associated with longer lengths in treatment, simply because in those situations, like in kind of a twisted way, that's actually forcing women to put themselves first, because there's an external pressure that's saying that you need to address this in order for you to continue to play the role that you are that really care about and that find fulfillment in. And so in that way, it's really creating kind of this pressure for women to actually put themselves first within that situation. And women are also more likely to stay in treatment if they've had prior successful experiences in other life areas, and out of that possess confidence in treatment process and outcome. There's nothing more debilitating than someone really believing that recovery is impossible, than crushing someone's hope to actually believe that recovery is possible, that a different life is possible, that they are worth recovery, that they are worth more than what they feel that their life is consumed with at that point. And these are all really important factors when thinking about not only helping women get into treatment, but stay in treatment and to be able to put themselves first. Next slide, please.
Thank you, Mikaela. we're gonna jump off of that and talk about substance use disorder in pregnancy. So let's go over some primary concerns. And apologies, this is a loaded slide, but we're gonna get through it. This is a high risk age group. The age cohort between 18 to 29 manifests the highest predilection for the development of substance use disorder, persisting as an elevated risk demographic throughout the reproductive span, specifically between 18 to 44 years. Substance use disorder, not surprisingly, is underreported. The prevailing underreporting of substance use during pregnancy underscores the confluence of shame and guilt that we've been talking about among women, and then specifically pregnant women. It really inhibits candid disclosure of their substance utilization. That, of course, is a barrier to care. A decline in the utilization of basic gynecological services characterizes pregnant women afflicted with substance use disorder. This is associated then with delayed pregnancy recognition and at times complete avoidance of prenatal care. So here's the opportunity. Intervention and education. This is a time of child rearing years, and it's an important opportunity for intervention and education. Quickly identifying and working on improving substance use disorder during pregnancy can make a real difference in the outcomes for both moms and babies. And moving on quickly, just to address the stigma of neonatal abstinence. Neonatal abstinence syndrome can be treated without causing long-term issues. It's crucial to correct the use of the term addicted for newborns, as it wrongly stigmatizes that neonatal patient and family. So how do we combat using these misconceptions? Well, like other matters, using precise terms for newborns is crucial. Presenting these babies as victims only makes things worse for their moms and contributes to the criminalization of the disease of addiction. So just to summarize, carefully thinking about these issues and taking advantage of the right times for intervention and education can really improve the outcomes for moms and babies dealing with substance use disorder. Next slide.
This next section, we're going to dig into external impacts to consider. If you want to hit the next slide. The role of intimate partner violence is a really important thing to discuss when talking about helping women in recovery progress, simply because we know the role that that plays in leading up to women developing a substance use disorder and in their recovery journey. So I want to hit some statistics on this. So intimate partner violence is the strongest known risk factor for being a victim, is being a female. Just like being a female means that you are at risk for this. 1 in 4 women experience severe intimate partner violence, sexual violence, and or stalking. 1 in 3 women have experienced some form of IPV. 1 in 10 women have been raped by an intimate partner. 1 in 7 women have been stalked by an intimate partner, and only 34% of those who are injured as a result of intimate partner violence actually receive medical care. And then there's some statistics here specifically on sexual assault. But really what this emphasizes is that this is a very serious and all-consuming issue that face women in any format that they're seeking health in, but especially in treating addiction and the trauma that a lot of these women occur or actively engaged in the process of them seeking treatment. And substance use increases the risk of future assault because of the environment that women are in, as well as just the mentality that they have about themselves and their protective factors in place as part of that. It really can become a vicious cycle where intimate partner violence leads into substance use, which then perpetuates being in the environment where they continue to be abused. And that's a really dangerous and hard cycle for women to break in the process of recovery. Next slide, please. The connections, additionally, building off of that, separate from intimate partner violence in and of itself, is just the way that relationships play a role in women seeking treatment and women being able to engage in treatment. So women often view shared drug use with their partners as a means of connection or relationship maintenance. That if that is a core part of their relationship and who they are as a couple, it can be really difficult for women to separate from those actions with their partner when they are thinking about seeking recovery or in the process of recovery. Additionally, gender dynamics and drug use are important characteristics to consider as well. Male partners often initiate rituals around drug use. So in romantic partnerships where both partners inject drugs, there's oftentimes a division of labor where men are responsible for obtaining, purchasing, and injecting the drugs for them, and therefore sharing needles or using drugs with a partner may create a feeling of emotional closeness for women or indicate an imbalance of power in the relationship. Women face high risks of HIV and AIDS and hepatitis due to sharing needles or engaging in sexual relationships with drug injecting partners, simply because they feel less empowered to say no, or they feel that it's an attack on their relationship if they're resisting following the partner's lead on that. Relationship status and substance use. Marriage appears protective against substance use disorders. Separated, never married, or divorced women are at a greater risk for substance use since development, but I say that with a grain of salt, as it really depends on how healthy the marriage is. That some marriages can really be a detrimental effect on women in wanting to address their mental health. That really has to be individually approached and thinking about what's going to serve each woman well in their journey of recovery. And then continued relationship influence. Relationship status continues to influence treatment beyond entry. So relationships significantly impact treatment engagement and continuation. Breakups, makeups with a significant other who's continuing to use or other party really impacts women's ability to be able to stabilize and to be able to move forward. Women who are involved in a relationship with someone who's in active addiction statistically are not successful in recovery, simply because of the way that really influences their ability to separate themselves, to be able to move forward in recovery and their own view of their self-worth in that process. That the women who are successful are statistically more likely to be successful if they separate from a partner who's in active addiction, simply because of the influence that relationship has on them. Next slide, please. I think I also want to touch on family history and relationships because I think that's important and kind of getting at the core of what it looks like and thinking about the psyche of being a woman in recovery. So, again, I say this with a grain of salt because every woman is unique and different. But generally speaking, women tend to define themselves more in terms of their webs of social relationships and obligations. So having alcohol-dependent parents or other alcohol-dependent relatives, dysfunctional family patterns, any of those things really can contribute to women feeling they have a specific role that they need to play within that. And therefore, their inability to manage a million different hats oftentimes leads them down that pattern of trying to find something to help them cope with the unrealistic expectations that they feel are placed on them. Additionally, being introduced to and initiating alcohol and drug use through significant relationships, including boyfriends, spouses, partners, and family members, has a huge impact on women. That relationship being the key, and like I said earlier, the core of doing an activity together or using together, that can be at the core of a lot of women's relationships in that unhealthy dynamic, and therefore that becomes essential to a connection with their partner. And so breaking that habit is more than just breaking the physical act of that. In a sense, it's emotionally breaking your connection with that person. So when you're thinking about wanting to support and encourage and help women who are needing to take that step forward in recovery, there's some things to consider. Exploring acceptance of a patient's substance use among family and significant relationships. Discuss concerns regarding childcare needs, the type of support that they've received from their family and or spouse for entering treatment. Identify within the various caregiver roles that they play and how that impacts seeking treatment and impacts the way that they think about treatment and their own personal worth and role, as well as reviewing parenting history and current living circumstances. More than anything, though, women need to know that the people that are treating them care about them. They need to know that you want to hear their story, that you understand that they have unique struggles that they're facing, and that they deserve to be able to have a space where they're heard, where they're valued, and that they're supported in their recovery journey. Next slide, please. One question that oftentimes comes up when thinking about helping support women in recovery are whether having children in that process incentive or barrier to treatment. So we're going to touch on that briefly here today. women are actually much more likely than men to enter treatment because of the way that it impacts child custody. So that actually is often an encouragement in the sense of women seeking treatment. Again, like I referenced earlier, not because of the criminalization of it, but more so because that forces the woman to put themselves first and thinking about how do I take care of myself so that I can take care of my child, and really viewing that as being the priority in that moment. If they're able to have access to their children during treatment, that's actually a huge positive for most women, as they're more likely to enter treatment, participate and stay in the program, and maintain abstinence. Likewise, women with children in treatment have better treatment outcomes in other major life areas compared to those who don't have access to their children. And women in recovery see the support of their children as an essential ingredient to their recovery, that being a main motivator, a main driver, a main core of who they are and why they're choosing to lean into this and seek recovery. However, one thing to note is that children can be a barrier in seeking treatment at times in the sense of a lack of childcare or fear of retribution for having children taken away. Like Mandy referenced earlier, a lot of times women are fearful, to be honest, when they're pregnant or when they're dealing with child care issues or their environment, because they're fearful of having their children taken away. And so one of the best ways that we can help support women is not removing children, but giving them access to resources and helping them be able to find healthy ways to navigate through that when appropriate. Obviously, every situation is different, but women having access to their children is always going to be more positive in the long run for their recovery than not. Next slide, please. What I want to talk about next is a real story of a individual that I had the pleasure of working with here at BrightView. So I want you to meet Cassie. So when she first came to seeking treatment at BrightView, she was 30 years old, and she presented with having an alcohol use disorder, an opioid use disorder, a generalized anxiety disorder, and obsessive compulsive disorder. She had a pretty significant history of trauma and abuse throughout her life, and her main motivation for treatment was that she wanted to get her son back in her life. So at the time that Cassie entered treatment with us, her son had been removed from her custody, and she had over the two years prior to that. And over the course of the 2 years, she had had several what she termed failed stints in different inpatient facilities in the state. And so in her mind, she was wanting to try something new and was hopeful that she would finally be able to, quote, get it this time, because she was worried about running out of time to be able to reconnect with her son. When Cassie first started treatment, she really was just focused on, I just need to get my son back in my life. What are the things that I need to do to look good on paper so that my ex-significant other will let me have access to him? That's my main motivator. But throughout treatment, Cassie was really able to identify a lot of the underlying trauma and abuse that led to the feelings of shame and guilt and lack of self-worth, and led to a lot of her both substance use disorder but mental health disorders as well. And through that process, Cassie was able to identify that her identity as a woman was really wrapped up in her feeling that she was never enough, that there was this core belief that she was holding on to, that she could never be enough. And out of that, she was constantly, whenever, a situation came that she felt like, oh, another example of how I'm not enough, she simply was trying to cope with this and trying to control things that she had control over or things that she didn't have control over out of a desire to not feel that way. And through being able to address that core identity, Cassie was really able to actually begin to walk the road of long-term recovery, because she was able to identify the core of what women's specific struggles she was facing and how that influenced the way that she approached herself and the way that she approached treatment. And it was such an honor, a privilege to walk along with Cassie, and I think really demonstrates how there are so many unique struggles that women face, and it's so important to get at the core of what they're really wrestling with and experiencing in order to help them feel heard and valued and be able to navigate their recovery journey. Next slide, please.
Thank you, Mikaela. We're going to move into the third and final section of today's presentation, and it's providing effective treatment. When it comes to engaging women in treatment, the slide in front of you is from SAMHSA, which most of us, or all of us, I'm sure, are familiar with. And while it is a few years old to date, the trend on this particular chart, it still continues. Across the bottom of the chart, you will see all of the behavioral health concerns that affect women. And if you look, the two largest buckets represented is SUD, substance use disorder, and any mental illness. And as we've talked about a lot of times, when for women, there is a co-occurring or comorbidity issue that happens along with the disease of addiction. But what is startling here is of these two largest buckets of substance use disorder and all mental health concerns, the staggering number of women suffering with one of these issues, but the percentage of those that are not getting treatment. If you just look at the substance use disorder bar for a moment, you've got 18 million women reported suffering with a substance use disorder, and 93, almost 94% are not seeking treatment. And that is scary to me. All of us here today know that we are not dealing with the same landscape when it comes to behavioral health concerns. And when I say behavioral health, I am including the disease of addiction and substance use disorder. 10, 15, 20 years ago, things looked very different for those of us that were out there and suffering. And today, and I mean, this sounds kind of harsh, but today this is actually can be a death sentence for women. And that is why all of us at BrightView are so passionate about bringing information like this to light and continuing to talk about it, breaking down the stigmas and lending a hand really to anyone who wants help from these issues. We're 80 plus centers strong today, I think. Don't quote me on it. I always don't know how many places we actually can help people. But I very much believe that all of us on this call, all of us at BrightView, we really are making a difference. And I think that's something that's important for us to stress today is that, even though they may be baby steps and there's still lots of work ahead, look at this chart, but we are making positive steps. Next slide. So, while addiction doesn't discriminate, we all know that, I think being mindful of the female's journey when they're starting the recovery process is really key. I think Mikaela hit on this. I think actively listening to a patient or client, really supporting them rather than assessing them, so to speak. I certainly understand the importance of clinical assessment, and it's something that's very important in putting together treatment plans. But I think the approach with women has to be one where it's comforting and supportive and non-stigmatizing and non-confrontational. Because as you build that rapport with the woman, you're creating a safe space for her. And as you're creating a safe space for her, she is able to then take deeper dives into her own history and her own trauma. And for those of us that work with that population, that actually is good for us. That allows us to provide better care to her, because as she's divulging more information about her history or her current environment or what some of her major stressors are, whether they're social or otherwise, this allows us to build treatment plans around women that are actually far more effective and allow for a sustained recovery journey. So some of the things mentioned on this slide are important when working with the female population. Women stick with the women. That's kind of been one of the things that was always told to me. You participate in gender-specific therapy groups, providing trauma-informed care. I mean, if we're not if we're not, I don't know that we, and Mikaela, I can defer to you on this. I mean, I think we talked a little bit about it offline, but when a woman first seeks treatment, I don't know that she's necessarily ready to jump into her trauma history. But as some of, as some of that becomes available to the care providers, I mean, those are where we can tweak the treatment plan and really, really give her a good shot at living a life of sustained recovery. Next slide. And then we're going to look at gender responsive treatment principles. I apologize, I'm not going to read the slide to you, but I think early recovery is some of the most difficult time for those, and especially women who are choosing a new way of life. Utilizing gender responsive treatment principles can assist a woman through some of these challenges. We've talked about recovery being a journey. It's not true that once you stop utilizing alcohol or other substances that life is just well, right? I mean, life continues to happen. And I will tell you personally that some of my most challenging times were in the first 2 years of my recovery. And having the support system around me that allowed me to feel my feelings. I mean, that early recovery, you're not numbing anymore, right? You're not running from your feelings and from your life as your life is. And again, it wasn't a once and done thing for me. I mean, it's happened many, many times during my 17 years of sobriety where, we're dealing with a chronic disease here. I've often been told that sometimes the farther away you are from your last use, the more active or the disease can get, right? Because we are still living with this chronic disease. And I can tell you, had I not had a supportive team to assist me through this, I wouldn't be in front of you today. And that means clinical support. That means peer support. That means learning to put myself in safe places when I'm not feeling safe. And again, I've always stuck with the women, female clinicians, gender-specific recovery groups, female trauma programs, and the list goes on. But the main thing that I want to share with you for me and my journey is I look at recovery for me as a pink tool belt. It's a pink tool belt. And every morning I get up and I put my pink tool belt on, and I make sure that all of those things that I just mentioned are part of that tool belt. Do I have a support system around me? Is there someone that I can call if I need to talk to someone? Do I have, good clinical support around me if that's needed? So I think that's a funny analogy in some aspects, but it works for me because it's a toolkit. I mean, you cannot, when you're living with a chronic disease, you have to learn to manage it. I mean, trust me, my God, I wish, I could have done it in 1 year's time and been well back on my way. But that wasn't my destiny. So, I want you all to remember that pink tool belt and how all of us are responsible for providing tools for our patients and clients to help them through this process. The last thing I'll mention on this slide is a lot of times we'll say, well, where are women coming from when they do actually seek treatment? I mean, where are the referral? Where are they coming from? A lot of them can be self-referrals. I mean, I know for myself, the pain became enough. Pain's a great motivator, and pain became enough that where I said, I've got to do something. I'm not going to survive. We talked about the justice involved. Certainly that is another area along with DCBS and Child Protective Services. So next slide, please.
Thanks, Amy. Building off of that and thinking about how to help women have specific engagement in treatment and how we can be mindful about setting them up for success in that way. There are lots of really excellent approaches, but three that I want to hit on today are including making sure that we're operating from a trauma-informed perspective, maintaining a gender-responsive treatment environment, and using a strengths-based approach to treatment. So hitting on adopting a trauma-informed perspective, I want to talk about two aspects of that. A trauma-informed perspective is not just assessing for trauma and treating trauma in a behavioral health therapy session. It's about the way that the environment operates and understanding the way that trauma impacts the way that people operate and the way that it impacts their ability to regulate themselves and be triggered in environment. So, trauma-informed perspective means that the person who greets them at the front door or at the front desk is welcoming, is warm, is respectful, looks them in the eye, and creates a safe environment that can help speak to saying, this is a safe place for you to be. We're so glad you're here. You are welcome here, and we're going to help you navigate this every step of the way. This is a terrifying experience for most women to enter treatment, not because they don't want treatment, but because they don't know what this means for who they are or the roles that they have or the people that depend on them. And there's so many things that they have to navigate to just walk through the front door. It's our responsibility to create an environment where people are feeling welcomed and empowered the moment that they walk into one of our centers. Additionally to that, it's really important that we are responsible about proactively screening and addressing and treating trauma in a person's treatment process. This doesn't mean that we want to rush people before they're ready, and it's very important, especially in early recovery, to assess about how stabilized someone's substance use disorder is before digging deep into their trauma. This doesn't mean that we don't want to address trauma before, they're in sustained remission, because a lot of those things tie hand in hand, but we don't want to approach addressing their trauma too soon before they have the necessary regulating and coping skills in order for them to dig deep into the underlying issues. And we need to make sure we're doing that at a pace that they're comfortable with and not rushing them in that process. The key there, I'll reiterate myself, is listening and following their lead about helping them feel empowered in this process, not controlled and dictated to. That also builds into a gender responsive treatment environment. Like I've said before, using a collaborative, and Mandy and Amy both spoke on this, using a encouraging place versus a dictatorship place is important, and using a collaborative environment where we are a team and helping the women move forward. We're not having them come to us for us to dictate what their treatment looks like. Our job is to put them in the driver's seat and help them navigate and take those steps forward. And we want to make sure that a key component of that is developing a healthy support system. Women are relational creatures, generally speaking. And so making sure that they can have a healthy support system for them to be able to walk along in their journey. That tool belt that Amy talks about, I think that's such a key component of who are the people in your toolbox? Who are the people that you're carrying with you every single day that are your support system in your journey? And then also operating from a strengths-based approach to treatment, I think, can be a really incredible, empowering place. Helping women identify successes or the strengths that they have in their life and how they can apply those to their recovery. Hey, you know what? What's a strength of yours? How much you love your kids? Great. That's a strength in recovery too, because that's a motivator to help you stay focused on that even when you're struggling. What's a strength you have? The way that you are always showing up for your mom? Great. That's a strength that you can have and apply to yourself, and the way that you can always show up for yourself in recovery. And it's really helping them identify how incredible they are as humans and how many strengths they already have and utilize every single day that they just don't realize and have never had anyone to help them be able to pinpoint that and really embrace who they are and embrace the version of themselves that they're becoming in recovery. Next slide, please.
Thank you, Mikaela. Thank you, Amy. Let's talk about relapse risks for a minute for women and just a couple of key points. So what we are seeing are gender neutral relapse rates. When it comes to alcohol relapse, the rates appear to be similar for both men and women, and gender doesn't seem to be playing a moderating role in this aspect. So predictors of relapse? Well, not surprising. Factors such as negative mood, childhood, sexual abuse, alcohol-related self-efficacy, and coping strategies predicted alcohol relapse. And again, interestingly, gender did not moderate those effects. There are, however, gender disparities, in marriage and relapse. So Mikaela touched on this, but this is just to underscore, we are looking at marriage as a risk factor for women. Marriage and marital stress emerge as risk factors for alcohol relapse. And this is in contrast to men, for whom marriage actually lowers the risk of relapse. So the why behind this is in the demographics. Women with alcohol use disorder are more likely to be married to men with a similar disorder, so heightening their risk of relapse. On the flip side, men with alcohol use disorder are more likely to be married to women without the disorder, so then that offers a protective effect. So factors that influence women's relapse: sensitivity to negative affect. So women relapsing in substance use seem to be more sensitive to negative affect, which includes feelings of emotional stress. They're just more sensitive to that. And so breaking that down, stress coupled with coping mechanisms emerges as a critical factor influencing relapse in women with substance use disorders. Unresolved issues, particularly trauma that Mikaela talked about, play a substantial role in women's susceptibility to relapse. The social and environmental context significantly impact a woman's risk for relapse. And the presence or absence of a robust support system plays a pivotal role in determining relapse likelihood, as Amy spoke to. So other contributing factors, they include overconfidence, complacency, lack of continuity of care and treatment plans and aftercare plans, and unrealistic expectations just contribute to that vulnerability for women to relapse. Women, in contrast, though not universally, may be more likely to experience relapse in the context of heightened sensitivity to negative factors. Men, on the other hand, may have experiences translated in their relapse as positive prior experiences. So understanding these nuanced gender dynamics in the context of relapse risk is crucial for tailoring effective intervention and strategies. Thank you so much. And next slide, I think Mikaela's got a story for us too.
Yeah, I just want to circle back to Cassie was the individual I spoke about earlier in the presentation and talking about how her journey in being able to overcome barriers to seek treatment and like her focus and the things that she was delving into and recognizing what was at the core of who she was and what she was wrestling with as she was seeking to be in sustained remission for her substance use disorder. And it was really cool to be able to share Cassie's story because Cassie actually graduated from BrightView about 2 years ago. She was doing really well and had met all of her treatment goals and had developed a support system in her community and environment that was helping her stabilize and be everything that she was wanting to be. And oftentimes with our patients, and I'm sure those of you on the call who have the pleasure of working with this population is we get to see people for brief periods of time, but we don't always know what their stories look like and what their lives end up looking down the road. And a couple weeks ago, one of my coworkers was actually out to eat with her family, and who happened to be waiting her table was actually Cassie. And it was such a cool experience to be able to have them connect. To Cassie share that she's in sustained remission, continued on for 2 years. She was celebrating her 3 years of recovery. And, you know, she had twins that she had given birth to in the last year and was approaching their first birthday. And just to be able to hear what a transformation that her life had become and what an honor it was, and a tearful reunion for the two of them to think about where she had started and where she was to this day. And I think that those stories are really important to hold on to because they represent that of all the information we go over, it's important to understand the facts and the certain things we need to do in order to make sure we're treating women in an evidence-based way to best set them up for success. But facts aside, women are just real people. They're our sisters, our mothers, our best friends, our aunts, our children, our daughters. They're the people in our lives who we love more than anything. And we need to make sure that we're keeping in mind that these are real people and that recovery is possible every single time that we have the pleasure of treating someone in front of us. Thank you for your time today. I think wrapping up, we're going to head into questions. So I will turn it over to Kevin to moderate that.
Yeah, thank you, man. This has been great. Yes, we do have some really good questions from folks. And first one I want to serve up is, what do you do with a patient who identifies as female but was not assigned the female gender at birth?
That's a great question. I'll jump into this, but happy to have Mandy and Amy also jump into it as well. I think it's important that we show people the respect of treating them how they want to be treated. And so being mindful of how they're presenting, the way that they wish to be addressed or way that they wish to be treated, and more than anything, listening to them. This is obviously important information that's done research on women, but it's important to not let that skew and apply this thoughtlessly in the way that we approach treatment, as treatment needs to be individualized. And the most important thing is to listen to the person in front of us and make sure that we are following their lead in their treatment and recovery journey.
That's great. And another one is, we're obviously always trying to evolve the language to be more inclusive and whatnot. When it comes to, and you had mentioned this, I believe, Mikaela, when it comes to changing the term used to describe a baby born with an SUD, one of our attendees wanted to know is saying the term substance exposed infant, is that less stigmatizing and accurate?
I'm going to pivot that to Mandy because I think she actually talked about that.
Yeah, I think I thought I was muted, sorry. I think either would be appropriate. I have heard both used interchangeably in my practice, either here within BrightView in discussion or in my former years as a pediatric nurse leader. So I don't know that there's a right or wrong answer there. I think we all know in this space of addiction and mental health care that our terminology changes with some frequency, and we work hard, all of us, to adapt to meeting the needs of those populations. So again, I don't think there's a right or wrong answer there, and I believe that is appropriate as well, and we do hear them both.
Sure. And if we know that women who have anxiety are more likely to relapse, how can we try and address this as a service provider?
I think that we just make sure that we are aware of this and let that have the lens in the way that we approach treating women's anxiety. So if someone's presenting with anxiety, we want to make sure that we are including that in their treatment plan if the patient's willing, and making sure that we're not minimizing the impact that anxiety plays on their day-to-day management of their substance use disorder. I think that a lot of times symptoms of anxiety can be overlooked or diminished in women and saying like, oh, they're just, being dramatic, or, oh, they're just hormonal, versus actually truly recognizing the symptoms of anxiety for what they are, which is a disorder. And we need to make sure that we're helping people develop the tools to address that and not just dismiss that.
And as it relates to the trauma issue, do any of you have some helpful trauma-informed resources that the audience might check out just to be, more self-aware of that and how they might change up their approach with patients as a result? I can kind of leave that one out there if you guys want some time to think about that and move on to the next one. That next question being, how do we promote healthy relationships and connections with others in treatment? This individual is a case manager, and they've struggled to do this for their clients in the past.
Amy, do you
I
want to
think
jump into that one? Or go ahead, Mandy.
yeah, I was gonna pick on you, Mikaela. No, so
I feel like I don't I just like would love to hear the people's feedback as well. Can you repeat the question again, Kevin?
Yeah, no problem. So this individual is a case manager and they've struggled with this in the past. They're just wondering how can we promote healthy relationships with others in treatment. And I'm assuming and this person's feel free to jump back into the chat if I'm misinterpreting this, but I'm assuming this means, many, it's addiction could be, a very private thing and participating in things like group counseling, for example, might be tough for them, but obviously at the same time, they can forge some really good relationships there and connections. And I'm assuming that this individual is just wondering, is there a way that they can promote this as a case manager? It's arguably, the resource for them that they can tap into.
Yeah, that's a great question. I think building healthy relationships and learning like healthy boundaries and what it means to be in a relationship with someone where you don't become codependent, especially early in recovery, is really important. Just all the nuances of what that looks like. So I think that there's two facets there. One is in an individual setting, it can be really good to dig at to the core of what core beliefs women may be wrestling with, or what specific incidents or trauma that they've experienced in their life that influences the lens that they approach relationships and the way that they view what healthy relationships even are and look like, and therefore seek to engage and model that in their life. And then the other aspect is thinking about anytime you're learning a new skill, sometimes you got to just practice it. And so being able to create an environment or groups or community support where women are able to start to be around other people who are in healthy journeys or are in the process of becoming healthy themselves is really important and powerful in being able to provide people that community and to like kind of learn and grow and work through those dynamics alongside each other. So I think that there are different ways to approach that, each kind of digging at the core of wanting to create an identity of what healthy relationships look like and how to pursue that in their personal life. Let me know if I'm answering your question or not.
I think actually you took it to a good place based on the clarification an individual added. Also, I would encourage folks, if you guys know of some trauma-informed resources, Carrie Goodson, thank you for doing this. She's an attendee here and just added she knows someone that teaches trauma-informed care and listed this person's name and contact information. So that's great. If anybody else wants to add to that, please do. And someone in the meantime asked if we know how long on average does a woman spend in a recovery program?
Yeah, that varies in my experience, but I would love to have the other panelists speak to that because that's really going to be individualized to each person in their recovery journey, what that looks like. Amy, you mentioned kind of earlier, like it would have been nice if that would have been a year, but that wasn't my journey. You know what I mean? That like I think that there is like, ups and downs and twists and turns in every person's recovery. And because of the unique factors that women face, it oftentimes takes them longer to get into treatment to then actually start the process, which means that a lot of times there's a lot of things and baggage to unpack that will sometimes lengthen the time in treatment. But again, I think it's important to keep in mind that I think that it's vital that we understand what the science says and what research says about how to best support women, but that cannot take away from listening to the person in front of you. That has to be the core of how we operate, regardless of any statistics, so that we truly are empowering them in their recovery journey and helping them be able to develop the life they want versus trying to get them to meet our specific timetable.
But going back to the science, I mean, I do think that at least what we know today from a substance use standpoint, if there's a history if there's a history of substance use disorder, prolonged use, it takes the brain a long time to get back on board after, for someone like me, I know for 2 or 3 years of my early recovery, my brain still was not healed. And, so Yes, it is very individualized, but on average, the first few years of recovery, you got to let that brain heal. And that's one of the things I love about BrightView is that, we are the only outpatient model that I'm aware of that's model is designed to support that patient or client through those first, few years of this process, because we know that the relapse rate is so high, and because of that brain chemistry not being back, where it needs to be. But again, it's a chronic disease and things are going to continue to pop up in life. And, that's why that tool belt is so important. And that's why, for someone like me, I'll probably never be out of therapy, quite honestly. I will never not need clinical support. Whether that's trauma related or depression, anxiety related, the comorbidity thing. So I think the best treatment providers are the ones who are truly treating the individual and not putting a specific time frame on what it's going to take for this person.
Great. Okay, we have one final question here that we're able to address in this time since we are over, but an individual's asking about, younger patients in recovery have made it clear they would be more responsive to treatment if it was more technology-based. And with that being said, obviously, I think we could speak a little bit to telehealth, but they also want to know if there's a recommended app that might be out there for folks seeking treatment options independently. I suspect that might be helpful for folks in rural areas as well.
I don't have a particular endorsement. There are many new platforms out there, and we at BrightView have really worked on tailoring our internal resources to the client, as you mentioned, Kevin, around some of our telehealth pieces that help make the care more accessible for the patient, as well as our local presence in the communities that we serve, helping those that they're located very close to the individual and in their home areas so that they can manage their care that way. But I definitely know that's a growing area for all of mental health and recovery. So I'm excited for that, for our future, for our younger patients who are much more tech savvy these days.
Well, and I know that there's been a lot of work around prescriptions being virtual now and through apps and whatnot, and there's been some starts and stops there. HIPAA obviously is a big part of this as well. I want to make sure that right folks get the right treatment. So I suspect we will be seeing a lot more of that in the future. But yeah, telehealth is usually an option with a lot of providers if that's required for sure. So we just want to thank everybody for your time. Really